Pratima from Planet Physiology. Today we shall learn how urine is concentrated whenever body needs to conserve water. At the end of this session, you will be able to understand the purpose of urine concentration, requirements for concentrated urine formation, concept of countercurrent flow, role of countercurrent multiplier and countercurrent exchanger in concentrated urine formation, role of urea in urine concentration, concept of obligatory urine volume and clinical aspects related with concentrated urine formation. What is the need for concentrated urine formation? Basically, it is to preserve or maintain body fluid volume in case of reduced water intake. This is especially important in dry desert conditions where there is scarcity of water. By forming concentrated urine, water excretion in the urine is minimized, and for this purpose there is need to secrete large quantities of ADH as well as presence of hyperosmolar renal medullary interstitium. This renal medullary hyperosmolarity is created by the mechanism called as countercurrent multiplier and maintained by countercurrent exchanger system. Before going to this mechanism, let us first understand the concept of countercurrent flow. It means inflow runs parallel, opposite and in close proximity to outflow for some distance. This countercurrent blood flow is seen in cutaneous vessels, spermatic vessels, vessels of intestinal villi and vasa recta, and also in the filtrate flow in the loop of Henle. Now let us study the mechanism of urine concentration. Concentrated urine formation is the function of juxta medullary nephrons which have long loop of Henle running up to the tip of renal medulla and the special set of capillaries surrounding them called as vasa recta. Even though these are the main components of the kidneys involved in formation of concentrated urine, collecting ducts also play significant role in this process. The first step in urine concentration is creation of hyperosmolar medullary interstitium, and it is created by countercurrent multiplier mechanism which is operated at long loop of Henle's of juxtamedullary nephrons. This picture shows juxtamedullary nephron and its relation with renal cortex and medulla. So shown in blue color is the renal cortex and shown in this greenish color is the renal medulla. This is the juxtamedullary nephron and you can see loop of Henle is reaching till the tip of the renal medulla. To understand countercurrent multiplier mechanism, you must know about the basic functioning of loop of Henle. Descending limb of loop of Henle is only permeable to water but not to solutes. That is, it can reabsorb water but not the solutes. Thin ascending limb of loop of Henle is impermeable to water but allows diffusion of solutes, whereas thick ascending limb of loop of Henle reabsorbs solutes by active transport but is impermeable to water. Hence, it is also known as diluting segment. The filtrate that enters the descending limb of loop of Henle from proximal convoluted tubule has osmolarity of 300 milliosmoles per liter, whereas the filtrate that leaves the ascending limb of loop of Henle is hypoosmolar. Now let us start with the process of countercurrent multiplier mechanism. For the sake of understanding, these steps are dissected and discussed one after another, but in our body these are operated simultaneously. So in the beginning, osmolarity of the filtrate is same, that is 300 milliosmoles per liter in the entire loop of Henle as well as medullary interstitium as shown in this diagram. Blue color background represents medullary interstitium and U-shaped structure is loop of Henle. The numbers represent osmolarity in the interstitium and filtrate in the respective compartments. As the filtrate enters thick ascending limb of loop of Henle, pumps start to reabsorb solutes like sodium, potassium, chloride, calcium, etc. That is, these solutes enter the interstitium from the filtrate. As a result, solute concentration in the interstitium rises and that of filtrate in the ascending limb reduces. These pumps can generate a maximum concentration gradient of 200 milliosmoles per liter. So, these green color circles represent active transport process and the arrows represent the direction of the movement of solutes. So, as shown in the second diagram, due to solute reabsorption, there is creation of osmotic gradient between the descending limb of loop of Henle and the medullary interstitium. Descending limb has previous 300 milliosmoles per liter osmolarity, whereas interstitial osmolarity has now increased. So, there is osmotic gradient. This gradient initiates next step, that is osmosis. So, osmosis of water from thin descending limb of loop of Henle into the interstitium continues till the equilibrium is reached. As this segment is impermeable to solutes, removal of water causes solutes to concentrate in this segment. This leads to increase in osmolarity of the filtrate in the descending limb of loop of Henle. So, in this picture, the first panel of the diagram shows osmosis of water from the thin descending limb of loop of Henle, and the second panel shows increase in the filtrate osmolarity in the descending limb of loop of Henle due to osmosis, and it becomes same as that of medullary interstitium. Now, the new filtrate from proximal convoluted tubule enters the descending limb and pushes the previous hyperosmolar filtrate to the ascending limb. The filtrate entering the descending limb is always isotonic in nature. That means its osmolarity is same as that of plasma, that is 300 milliosmoles per liter. Again, the solutes are actively reabsorbed from the thick ascending limb of loop of Henle, and there is further increase in the medullary osmolarity. So, in this picture, first panel shows that solutes are reabsorbed from the filtrate that has entered the thick ascending limb of loop of Henle. This further increases the osmolarity of the medullary interstitium. As indicated in second panel, hyperosmolar interstitium again initiates osmosis of water from descending limb of loop of Henle to further increase the filtrate osmolarity in this descending limb. So, the next step is osmosis of water from the descending limb of loop of Henle. As a result of this osmosis, again the filtrate in the descending limb gets concentrated. Same is shown in this panel again. This number 5 indicates that pumping of solutes from the ascending limb of loop of Henle into the interstitium, it has created the osmotic gradient, and in the number 6, this osmotic gradient initiates osmosis and the filtrate again becomes concentrated in the descending limb. Now, again new filtrate enters the descending limb from proximal convoluted tubule and pushes this hyperosmolar filtrate into the ascending limb. And the solutes are actively reabsorbed from the ascending limb to further increase the medullary osmolarity. Thus, all these steps are repeated again and again to cause formation of hyperosmolar medullary interstitium. This repetitive reabsorption of sodium chloride by the thick ascending limb of loop of Henle and continued inflow of new sodium chloride from the proximal convoluted tubule into the loop of Henle is called as countercurrent multiplier mechanism. This process creates maximum of 1200 milliosmoles per liter osmolarity of the interstitium at the tip of loop of Henle. This is the maximum osmolarity that can be achieved in the renal medullary interstitium in humans. Why is this limit? We shall discuss this part in the end. Now, in creating renal medullary hyperosmolarity, active reabsorption of solutes from thick ascending limb of loop of Henle contributes to 60% of the total medullary hyperosmolarity, whereas remaining 40% is contributed by urea due to its recycling. So let us study how urea is recycled and adds to the medullary hyperosmolarity. Whatever is the urea filtered from Bowman's capsule, about 50% of it is reabsorbed from proximal convoluted tubule and remaining passes to loop of Henle. As the descending limb of loop of Henle absorbs only water but not solutes, urea gets concentrated in this segment and moves to the next segment. All the segments from thick ascending limb of loop of Henle till the outer medullary collecting ducts as shown in the red color in the diagram are impermeable to urea and hence its concentration further increases in these segments. But the inner medullary collecting ducts are permeable to urea and hence urea is reabsorbed into the medullary interstitium from inner medullary collecting ducts. From here again urea diffuses into the thin ascending limb of loop of Henle as this segment permits passive transport of urea. This further increases urea concentration in the filtrate. Thus, 80% of the urea is recycled before its excretion in the urine. What is the purpose of this urea recycling and its role in urine concentration? Urea is basically the most abundant waste product to be excreted in the urine, but it is also osmotically active. Hence, urea recycling from inner medullary collecting ducts to loop of Henle helps to increase medullary interstitial osmolarity. This allows excretion of urea with minimal water. It also saves energy expenditure for pumping of the solids from thick ascending limb of loop of Henle, which is active process involving ATP utilization. Now, another question that can come in the mind is, we are discussing concentrated urine formation, that is, urine form must be hypertonic, but the filtrate that leaves the loop of Henle is very dilute, then how will it be concentrated? Normally, distal convoluted tubules and the collecting ducts are impermeable to water, but in presence of ADH, these segments become permeable and can reabsorb water. Hence, whenever there is need for conservation of water, posterior pituitary secretes ADH, that is antidiuretic hormone, and it helps in water reabsorption from these segments of the nephron into the peritubular capillaries. Thus, now the filtrate entering the medullary collecting duct is highly concentrated. Its osmolarity is same as that of medullary interstitium. Thus, presence of ADH is essential in concentrated urine formation. Medullary hyperosmolarity that is created by countercurrent multiplier is maintained by countercurrent exchanger mechanism. This mechanism operates at vasa recta, the special long U-shaped capillary loops that run parallel to the long loop of Henle of juxtamedullary nephrons. Descending vasa recta is non-fenestrated, but ascending vasa recta is fenestrated, and blood flow in this vasa recta is very sluggish. These characteristics allow them to maintain the medullary hyperosmolarity. Let us see how. Osmolarity of the blood that enters the vasa recta is 300 milliosmoles per liter. Being a capillary, it is permeable to both solids as well as water. Since interstitium is hyperosmolar, solutes diffuse into the descending limb of vasa recta and at the same time water moves out from the vasa recta into the interstitium. As a result, as blood reaches to the tip of vasa recta, its osmolarity has increased to 1200 milliosmoles per liter and interstitium gets diluted. Now, as blood starts moving in the ascending direction, solutes diffuse back into the interstitium and water enters into the vasa recta. So, once again interstitium regains its hyperosmolarity and the blood that leaves the vasa recta has osmolarity of about 350 milliosmoles per liter. So only minute quantities of salts are lost. Thus, exchange of solids between descending and ascending limbs of vasa recta helps to maintain hyperosmolar medullary interstitium. Let us summarize the important points what we have learned. Countercurrent multiplier system operates at long loop of Henle of juxtamedullary nephrons, and this system creates hyperosmolar renal medullary interstitium. 60% of the hyperosmolarity is created by reabsorption of solutes from ascending limb of loop of Henle and 40% by urea recycling. Countercurrent exchanger system operates at vasa recta and it maintains hyperosmolar medullary interstitium. In distal convoluted tubules, collecting tubules as well as collecting ducts, water is reabsorbed in presence of ADH, and this helps in formation of concentrated urine. The maximum osmolarity of the urine in humans is 1200 milliosmoles per liter. So we have seen that humans can concentrate urine up to 1200 milliosmoles per liter. But the urine concentrating ability of the desert animals like desert rats or Australian hopping mouse is much greater than that of humans because they need to conserve more water. This limit is decided by the length of loop of Henle. So more the need to conserve body water, longer is the length of the loop of Henle and more is the urine concentrating ability. Next we shall study another related concept, obligatory urine volume. It is the minimum volume of urine that must be excreted per day to excrete metabolic waste products. It is calculated as the amount of solids to be excreted divided by maximum concentrating ability of the kidney. For an example, a 70 kg man must excrete 600 milliosmoles per day and his maximum concentrating ability of urine is 1200 milliosmoles per liter. So if you substitute the values, you get obligatory urine volume as 0.5 liters per day. This means man should form 500 ml of urine per day to excrete the metabolic waste products. Now, if the concept of obligatory urine volume is clear, you can understand why one should not drink seawater even in emergency situations like when a person is trapped in the middle of sea and his drinking water is exhausted. If a person drinks say 1 liter of seawater in emergency situations, seawater osmolarity is 2400 milliosmoles per liter. Now he has to excrete all these extra solutes, that is 2400 milliosmoles in a day. His maximum urine concentrating ability is 1200 milliosmoles per liter. So his obligatory urine volume becomes 2 liters per day. That means there has to be formation of 2 liters of urine per day for every 1 liter of the seawater that is drunk. So finally this person will end up in severe dehydration. Now let us study some clinical aspects related with urine concentration. First is use of drugs like furosemide or Lasix. These drugs inhibit active transport of solutes in the thick ascending limb of loop of Henle. As a result, there is no creation of hyperosmolar medullary interstitium and hence no urine concentration. This causes formation of dilute urine which is more in volume, thus increases urine output. Hence, these drugs are advised in patients of renal failure to increase their urine output. Second condition is diabetes insipidus. It can be due to lack of ADH secretion by the pituitary, or it can be due to mutation of V2 receptors or mutation of aquaporin 2 proteins. These two reasons will lead to nephrogenic diabetes insipidus. So if ADH is lacking, DCT and collecting ducts cannot absorb water, but in case of nephrogenic diabetes insipidus, in spite of presence of ADH, DCD and collecting tubules and ducts cannot reabsorb water. As a result, dilute urine with more volume is excreted. Because for formation of dilute urine, no extra conditions are required. Mere absence of ADH will cause formation of dilute urine, as water will not be absorbed from these segments. So, in case of diabetes insipidus, urine formed is hypotonic with less osmolarity. The minimum osmolarity reached is 30 to 50 milliosmoles per liter. Next concept is measurement of osmolar clearance. It gives idea about amount of solutes cleared from the plasma in each minute. For example, if urine osmolarity is 600 milliosmoles per liter and plasma osmolarity is 300 milliosmoles per liter and urine flow rate is 1 ml per minute, osmolar clearance value is 2 ml per minute. It means that 2 ml of plasma is getting cleared of the solutes each minute. This osmolar clearance will help you in knowing whether urine formed is dilute or concentrated. So, you can calculate free water clearance as difference between the water excretion, that is urine flow rate, and the osmolar clearance. If the value of free water clearance is positive, it means excess of water is excreted in the urine, or in other words, urine formed is dilute. If value of free water clearance is negative, it indicates excess of solutes are excreted in the urine, that means urine formed is concentrated. In simple way, you can say that if urine osmolarity is more than plasma osmolarity, concentrated urine is formed, and if urine osmolarity is less than plasma osmolarity, dilute urine is formed. So, this is all for this session. Thank you. If you enjoy my sessions, press the like button and share it with your friends. If you haven't yet subscribed my channel, press the subscribe button. To get notifications about new releases, press bell icon. Thank you for watching and see you in the next video.